Assalamu alaikum wa rahmatullahi wa barakatuh. We will discuss osteomyelitis and arthritis. By the end of this lecture, you should be able to define and compare between osteomyelitis and arthritis, list the different causes of osteomyelitis and arthritis, describe the pathogenesis, clinical picture of osteomyelitis and arthritis, compare and contrast between septic and aseptic arthritis, describe the pathogenesis, clinical picture of viral myositis, outline diagnosis, treatment, and prevention of osteomyelitis and arthritis. What is osteomyelitis? Osteomyelitis is a progressive infection that can include one or multiple parts of the bone. It is usually subacute to chronic infection that can cause severe disability if not properly treated. Most of infections are caused by Staph aureus. The main player in osteomyelitis as a bacteria is Staph aureus. Also, there are other causative organisms with various predisposing factors causing osteomyelitis, like Streptogalactia in neonates, Staph aureus in children and adults. We said before that Staph aureus is the main player in osteomyelitis. Staph aureus and Mycobacterium tuberculosis in adults with vertebral osteomyelitis. Staph aureus, Pseudomonas aeruginosa, Serratia, and Candida albicans in intravenous drug users because of using unsterile water in cleaning reusable syringe. They don't use sterile syringe, so Pseudomonas aeruginosa may be contaminate syringe. Pseudomonas aeruginosa also in puncture wound of foot, due to puncture wound of foot. Pasteurella from cat bites. Salmonella species causing osteomyelitis in sickle cell anemia patients because of sickling of the blood, causing obstruction or occlusion of the small blood vessels and capillaries for bones. Occlusion of the GIT blood vessels, liver and GIT cannot act properly, so clearance of salmonella species is disturbed, causing salmonella bacteremia with salmonella for a long time, so may cause osteomyelitis in sickle cell anemia. So most of salmonella infection in sickle cell anemia patient in form of salmonella osteomyelitis. Coccidius amitus and Histoplasma capsulatum, fungal osteomyelitis generally due to exposure in endemic areas. The mode of transmission of osteomyelitis, the main mode of transmission and the most common mode of transmission is hematogenous spread from distant site to the site of osteomyelitis. So the most common mode and the very important mode of transmission is hematogenous spread. There is also direct extension from an infected contagious site, such as skin or soft tissue infection, direct contamination of bone following trauma that result in an open fracture or orthopedic surgery. The clinical manifestation of osteomyelitis is characterized by localized pain, fever, and tenderness to palpation over the affected site. With progression, the classic signs of heat, redness, and swelling may develop. It's a classical signs for infection or inflammation. In chronic osteomyelitis, necrosis of the bone occurs and a sequestrum formed. What is sequestrum? It's an avascular piece of infected bone. A vascular piece of infected bone can form at the site of the lesion. As a famous symptom of chronic osteomyelitis is an open draining wound over the infected site. It occurs later in the progression of the disease. This diagram showing hematogenous blood spread, hematogenous spread of osteomyelitis. As we said, the main or the most common mode of transmission is the hematogenous route. So this starts with a microabscess here, a microabscess, a septic focus related to a vascular loop. Then this abscess may expand and expand, going to the cartilage and to the periosteum. This expansion stimulate bone resorption around the abscess, stimulate bone resorption around this abscess, and also starting deposition of woven bone, reactive bone around this area, reactive woven bone around this area. Also stimulate the periosteum to form a reactive subperiosteal woven bone. Then the abscess continues to expand and expand to the cortex and the cartilage and to the periosteum, and perforate the blood vessel supplying the cortex and periosteum, leading to a necrosis in this part, leading to a necrosis in this part of the bone. As we said, more and more expansion of this part and the perforation of the blood supply, and then the necrosis of this blood part of the bone, this called what we called sequestrum. It's a vascular part of a bone. It's a vascular piece of bone. It's clear? Then it may be complicated if a chronic osteomyelitis occur, no proper treatment, complicated by a draining sinus through a periosteum, so all the joint space may be affected, and this part of the bone called a sequestrum. The viable reactive woven bone covering the sequestrum called involucrum. Okay, this sequestrum, meaning that dead or the avascular piece of bone surrounded by involucrum. It's a reactive woven bone covering the sequestrum. Okay. Osteomyelitis is a severe case. Unfortunately, it may be complicated by a major complication like an abscess in soft tissue, fistula or sinus formation, draining pus. Because of the sequestrum, it's a dead or a vascular part. Pathological fracture can occur. Extension into the joint producing septic arthritis. Gross disturbance due to epiphyseal involvement. the cartilage responsible for elongation of the bone and growth disturbed. So growth disturbance due to epiphyseal involvement. It causes also severe deformity with delayed treatment. If improper treatment or delayed treatment causing severe deformity in this part of the bone or joint. Laboratory diagnosis, we do some investigation. One of them, laboratory diagnosis, blood culture, as there is a bacteremia, especially in the hematogenous blood spread of osteomyelitis. Direct staining and culture, needle aspirate or biopsy from the bone, affected bone, for histology and pathology of the periosteum and or the bone. Like here, it's latic lesion in the metaphyses. Especially here, because it's the most common mode of transmission is the hematogenous transmission. So it's the most vascular area of the metaphyses of the bone. That's why the most of lesions located in this part. Okay, clear? Management of a case of osteomyelitis, we must start with a vigorous bactericidal antimicrobials, bactericidal antibiotics, which must be continued for several weeks to ensure a complete bacteriological cure, complete cure of the microbe present, and prevent progression to chronic osteomyelitis. We start by intravenous administration of the antibiotic, and then when the manifestation and signs and symptoms of inflammation like pain and inflammation disappear, oral antibiotic, shift to oral antibiotics, and the oral antibiotics must be continued for 3 to 6 weeks. Surgical drainage is also present as a line of management if there is a significant pressure from a localized purulent process. To refresh, acute osteomyelitis is commonly caused by which of these Candida, Haemophilus influenza, Salmonella, Staph aureus, streptobiogenes. The main player in acute osteomyelitis and osteomyelitis is Staph aureus. Arthritis. It is an inflammation of the surface of the cartilage that lines the joint and the synovial fluid that lubricates the joint. So arthritis, it is the inflammation of the cartilage line the joint and the synovial fluid. Okay, it either infectious or non-infectious. Infectious arthritis can be caused by a variety of microorganisms, including viruses, fungi, and bacteria. However, bacteria are the most common cause of arthritis. Infectious arthritis also classified into either septic or aseptic arthritis. Aseptic arthritis is either viral or reactive arthritis. So, arthritis may be infectious or non-infectious. Infectious arthritis is either septic or aseptic. Aseptic arthritis is either viral or reactive arthritis. Septic arthritis, it is a serious infection. It's a very serious infection, and if not treated quickly can result in a significant permanent damage to the joint and deformity and disability of the movement of the joint. So it is a very critical infection. The etiology and pathogenesis of arthritis. Organisms can enter the joint by either direct inoculation, contagious spread from infected periarticular tissue, or by hematogenous spread from a distant site, which is the most common route of infection. As we said on osteomyelitis, the most common route on osteomyelitis and arthritis is the hematogenous spread or hematogenous mode of transmission. There are two major classes of septic arthritis. It's either gonococcal arthritis or non-gonococcal arthritis. Gonococcal arthritis, from its name, it's Neisseria gonorrhea, is the most common cause in sexually active young adults. Gonococcal arthritis. Non-gonococcal arthritis, also the main player in this arthritis is Staph aureus. Other causative microorganisms of septic arthritis, as we said, Staphylococcus aureus is the commonest cause of separative arthritis. Streptococci, group A or group B streptococci, common in adults and children. Haemophilus influenza occurs in children, but nowadays it has decreased with the presence of H influenza vaccine or Haemophilus influenza vaccine. Neisseria gonorrhea may affect multiple joints. It's common in sexually active adult. Mycobacterium tuberculosis, often with bone lesions, especially weight-bearing lesions, joints and bones. Borrelia, arthritis, a late feature of Lyme disease. Gram-negative bacilli, neonates, maybe in neonates, in elderly patients with immune deficiency disorders. Clinical manifestations of septic arthritis: patients usually present with fever, joint pain, swelling of the affected joints, and impaired range of motion of this joint. Single or multiple joint may be involved or affected. The laboratory diagnosis, especially in the acute cases, blood cultures are useful because there is a bacteremia. So blood culture is useful in this in acute cases. The definitive diagnosis is established by examination of synovial fluid, white BCs count, gram stain smear, aspirate from synovial fluid, gram stain and culture may be beneficial. In cases of gonococcal septic arthritis, pharyngeal and rectal, cervical, and urethral specimen should be examined. The management of a case of septic arthritis: vigorous systemic antimicrobial therapy, usually bactericidal antimicrobial therapy, is required as soon as a diagnostic test suggests a bacterial cause or bacterial infection. This treatment usually must be continued for at least from 3 to 6 weeks, depending on the etiologic agent and the clinical response of therapy to the therapy. Drainage of pus is also an important aspect of management. Splinting the joint to keep it from moving, and avoid weight bearing on the joint or on the affected joint. Aseptic arthritis. Aseptic arthritis, as we said, it may be either viral arthritis or reactive arthritis. Viral arthritis is often called immune complex arthritis because the virus does not infect or affect the joint but by itself, but rather forms immune complexes with antiviral antibody that is deposited in the joint and elicit an inflammatory response. So no virus inside the joint, no viral invasion inside the joint. It's just an immune complexes inside the joint. So it's called aseptic arthritis. Immune complex arthritis. Such illness have been associated with many viruses: rubella, hepatitis B, mumps, parvovirus B19, varicella, Epstein-Barr, Coxsackie, adenovirus infection, some arboviruses. Nowadays, with COVID-19 infection, there is aseptic arthritis. The clinical feature of viral arthritis consists of either arthralgia. Arthralgia means painful joints, but without visible inflammation, no pain, no redness, no swelling, or frank arthritis in which inflammation is apparent. So it may be just arthralgia, painful joint, or frank arthritis with signs and symptoms of inflammation appeared. Most cases of viral arthritis are short duration and resolve spontaneously. Arthritis associated with viral infection is non-destructive. There is no pus cells, no septic focus to destruct or resorb el joint. But chronic arthritis may occur. Reactive arthritis, it is an inflammation of joint following previous infection by several bacteria that infect the gastrointestinal or genitourinary tract. The bacteria don't infect a joint by itself. So reactive arthritis, it's an inflammation or a sequelae for a previous infection by several bacteria, but there is no these bacteria infect gastrointestinal tract or genitourinary tract, but there is no bacteria inside the joint. No bacteria infect a joint. Rather, the arthritis is a result of the immune response to the bacterial infection. So the reactive arthritis, it is an immune response to the bacterial infection. There is many bacteria or some bacteria commonly associated with arthritis or reactive arthritis. Campylobacter, Shigella, Salmonella, Yersinia, and Chlamydia trachomatis. It's a syndrome called Reiter's syndrome. It's a syndrome called Reiter's syndrome, which consists of reactive arthritis, conjunctivitis, and urethritis. Okay? Also as a delayed sequelae after successful treatment of sepsis due to Neisseria meningitis or Haemophilus influenza may reactive arthritis occur because of the formation of immune complexes. Rheumatic arthritis. Rheumatic arthritis typically begins with a migratory polyarthritis, more than one joint, involving the large joints. So it's migratory polyarthritis in the large joints approximately from 2 to 3 weeks after streptococcal pharyngitis. It's a sequelae of streptococcal pharyngitis or acute follicular tonsillitis. Rheumatic arthritis. It's a migratory polyarthritis in the large joints. Okay? Non-infectious causes of arthritis. It must also be considered in the differential diagnosis of arthritis. They can closely mimic septic arthritis in its clinical manifestation. There is many causes of non-infectious arthritis, like collagen vascular disease, such as rheumatoid arthritis, gouty arthritis, traumatic arthritis, and lastly degenerative arthritis in old ages. Viral infections of muscle, what we call viral myositis. Some viruses, particularly Coxsackie virus B and influenza, especially influenza B in children, can cause pain and tenderness in the muscles. But it is not known whether this is associated with viral invasion of muscle or by some immunological response. Till now it's not clear the pathogenesis of viral myositis. Is it due to invasion of the virus itself, or it's an immune response to the virus? Myalgia are also seen in dengue fever and in rickettsia and other febrile infection, and probably caused by circulating cytokines. Post-viral fatigue syndrome. The post-viral fatigue syndrome or chronic fatigue syndrome is sometimes referred to as myalgic encephalomyelitis. It consists of chronic severe muscle weakness lasting at least 6 months, often as a sequelae to an acute febrile illness, severe tiredness, less regularly associated symptoms such as depression, headache, and anxiety. So what we call post-viral fatigue syndrome. It's a very clear syndrome, especially post-COVID syndrome. A severe fatigue, severe myalgia associated with the COVID-19 disease. Several viruses have been suggested, as we said, Coxsackie, Epstein-Barr, and COVID-19. Nowadays, COVID-19, it's a very clear syndrome, and as well as other viruses. It has also been suggested that it is due to allergic reaction triggered by virus infection. It's one of the theory. It's an allergic reaction. To refresh ourselves, rheumatic arthritis typically begins with a migratory polyarthritis involving the small joints. True or false? It's a false statement because it's Yes, it's a migratory polyarthritis in the large joints. Patients with sickle cell anemia have disposition to develop osteomyelitis caused by Salmonella species. Salmonella species, as we said, sickling of the blood, causing occlusion of the blood vessels of the GIT, so no clearance of the salmonella, and abnormal opsonization, and resulting in most common salmonella infection in sickle cell anemia in the form of Salmonella osteomyelitis. Thank you very much. Have a nice day. Assalamu alaikum.